Good evening. Tonight we are going to look at respiratory physiology. So we're going to look at how the lungs inhales air and exhales air, both passively and forcefully. We're going to look into what muscles are being used to do this. We're going to look at air pressure within and outside of the lungs and how this all works. So, of course, when we breathe in, it's called inhalation. And when we breathe out, it's exhalation. And let's look at when we are breathing in and out air, the pressure that is within our lungs, it can either be written in millimeters of mercury or atmospheric pressure. It is compared to what the atmospheric pressure is at sea level. And the atmospheric pressure at sea level is 1 atmosphere, or it's 760 millimeters of mercury. Both ways are correct to look at it, but I think most of this is going to talk about atmospheric pressure. So when we're breathing in and breathing out, it changes the pressure within our lungs. It also changes the pressure in the interpleural cavity. So we're going to kind of look at all of that. So when we see the term negative respiratory pressure, that just means that it's less than atmospheric pressure. When we see the term positive respiratory pressure, that means that it is greater than atmospheric pressure. And then when we see the terms zero respiratory pressure, that means that the atmospheric pressure is equal. So inside the lungs and outside the body, the atmospheric pressure would be the same. That is most of the time what we're going to be comparing, inside the lungs versus outside the body. The intrapulmonary pressure, means inside of, so this is inside the lungs, or the pressure that is within each alveoli. And that is called intraalveolar pressure. And when we breathe in or inhale and exhale, that pressure is going to change with each inhalation and with each exhalation. And when we're at resting, we're not inhaling or exhaling. That is when our lungs are exactly equal to atmospheric pressure. As I already kind of a little bit mentioned, we have intrapleural pressure. Intrapleural pressure is that pleural cavity that surrounds the lungs. So we have our lungs, then we have that cavity that goes around it, that visceral and parietal layer we looked at last week. That is the intrapleural cavity, or that pleural cavity, and it has its own pressure, atmospheric pressure as well. And just like the pressure on our lungs changes, just just the same way that our lungs, the atmospheric pressure changes when we breathe in and we breathe out, The same thing happens when that pleural cavity. It's always going to be about 4 millimeters of mercury less than the pressure within the alveoli. And we kind of discussed there's always some kind of fluid inside this pleural cavity. There's not a lot in there because we need the pressure in this cavity to be able to change. So if we have too much, it's going to get pumped out into the lymphatic system. We don't need too much fluid in there because we want to create that pressure difference that allows our lungs to expand and recoil back to their normal size. If we get too much fluid and it's not getting drained out, it can cause your lungs to collapse. There's two different forces that can cause your lungs to collapse. They have a natural tendency, once they've expanded, because they have a lot of elastic fibers within your lungs. These elastic fibers, when they get stretched, just like a rubber band, it wants to go back to its normal size. Well, so does the elastic fibers that make up our lungs. They always want to go back to their resting size. We also have what is known as surface tension. Surface tension is always there between a fluid and air. Any kind of liquid and air, there's always some kind of surface tension. If you think about a bubble with surface tension, once you blow a bubble, what causes that bubble to pop is actually the surface tension because that bubble is nice and round. There is surface tension being pushed in on that bubble from all angles. This is what causes that bubble to pop. Well, we have surface tension in our alveoli in our lungs as well. This surface tension is actually going to reduce the size of the alveoli once they've been stretched. So as our chest expands, our lungs expand, and because of those elastic fibers, our lungs will recoil and go back to their natural size as our chest wall will also go down back to its normal position. If we have a negative intrapleural pressure, it can affect the different forces, but it's kind of maintained because we have a strong force between that visceral and parietal layers of that pleural cavity. We also have transpleural or transpulmonary pressure. Transpulmonary pressure is that pulmonary pressure minus the intrapleural pressure. And what that is going to do is it prevents those alveoli from collapsing in on each other. We don't want our lungs to collapse. We want to keep some kind of tension in there at all times so our lungs maintain their shape. So as this says, the greater the transpulmonary pressure, the larger the lungs will be. So the smaller the transpulmonary pressure, the smaller the lungs will become. So if we have our intrapleural pressure equal to pulmonary pressure, our lungs are going to collapse. That's not a good thing. If we have our intrapleural pressure equal to atmospheric pressure, our lungs are also going to collapse. So that's why that intrapleural pressure must always be negative, less than what is kept in the lungs. There's only one time that that intrapleural pressure may become greater than the lungs, and that's during a forceful exhalation, kind of like a cough. That is when you are going to see that intrapleural pressure have a pressure that is greater than within the lungs. So let's kind of look at this picture of the lungs here. We have our pleural cavity with that visceral and parietal layer. We have that pleural fluid within that cavity, but it's going to have that slightly less pressure than within the lungs. The lungs, while at rest, when you're not breathing in, you're not breathing out, sits at 760 millimeters of mercury or 1 atmospheric pressure. That intrapleural pressure is always going to be about that 4 millimeters of mercury less, so about 756 millimeters of mercury when, again, you are at rest. But what happens when we have a pneumothorax? A pneumothorax is when something punctures the lung and air escapes out of the lung into that pleural cavity. So the first picture shows when a knife first goes into that pleural cavity, into that lung. We start with 0 as our atmospheric pressure because it is equal to the atmospheric pressure outside of the body. And that pleural cavity, the pleural pressure is about 4 less than within the lungs. But we've ruptured that pleural cavity and into that causes a hole into the lungs. Now the air that is stored within the lungs is going to leak out into that pleural cavity. And that's causing that pneumothorax or atelectasis, which is another name for a collapsed lung. And when we get that collapsed lung, the atmospheric pressure in that pleural cavity and within the lung is going to be the same. So as I just said, an atelectasis is a collapsed lung. There's different things that can cause a collapsed lung. It's not always a pneumothorax, but if something were to clog the air way down into those alveoli, through those bronchioles, it can cause those alveoli to collapse because no air is getting into them. Or as we just showed on the previous slide, that pneumothorax. And that is where the air from the lungs escapes into that pleural cavity. Can be caused from puncture wound. I was even taught when I was learning how to do acupuncture that even something as small as an acupuncture needle can actually cause a pneumothorax. So it's something that always should be watched out for, considering your lungs technically come up above your clavicles. So they come up really a lot higher than most people think they do. So if air gets into that pleural cavity, the only way to get it out is through chest tubes. You're going to have to take a chest tube of some sort into that pleural cavity and draw the air out of that cavity. So when that pleura that surrounds that lung, it self-heals because it's made of epithelium. And epithelial tissue is one of the best tissues in the body with regenerating. So it'll heal itself. And once that happens, the lung can reinflate. Pulmonary ventilation. That is what it's called whenever we breathe. And we breathe in and we breathe out. That is what helps to change the pressures within the lungs to help you breathe. So Boyle's law. Boyle's law kind of states that if I have a container here, got a lid on it, and we have all these particles inside. So if the size of this closed container, if I were to increase the size of the container here, the pressure of the gas inside this container actually goes down because you're giving that gas more space. You're not adding more gas to it, you're just giving it more space. So with making the container larger, the pressure of the gas inside of it decreases. And the same thing is true if you go the opposite direction. We have this larger container. If we were to go to a smaller container with the same amount of gas in there, the pressure is going to increase. So these different pressure changes is what causes us to breathe. So when we inhale, our lungs are going to expand. So as our lungs expand, we increase the lung volume. So we decrease the pressure in the lungs. Because remember, when our lungs are at rest, this is resting, that's actually going to equal 1 atmospheric pressure or 1 atmosphere or 760 millimeters of mercury. But when we inhale, our lungs get bigger. So when our lungs get bigger, the pressure inside the lungs actually becomes less than 1 atmosphere. So what muscles allow us to breathe? Our diaphragm and our intercostal muscles. Our diaphragm has that nice dome shape. So when you inhale air, it causes that dome to flatten out. And then when you exhale, that diaphragm makes that dome shape again. Our intercostal muscles. If you think about, we have our rib cage, we have our muscles that attach intercostal, so they're between the ribs. These intercostal muscles contract and they're going to lift that rib cage so you can breathe. It's going to lift it kind of up and out. Between the diaphragm and the intercostals contracting, both of them, because when the diaphragm goes down, it's contracting. That all allows that entire thoracic cage to enlarge. So it has, your lungs have that space to inhale air. So these pictures just show the different events when you're inhaling and when you're exhaling. And it shows how when the intercostals over in this far picture enlarge that thoracic cage. And then when you exhale, how those intercostals decrease that thoracic cage. So as we mentioned before, when you inhale, the lungs get stretched. So with Boyle's law, we are getting a bigger container. And when we inhale, which means pressure goes down. So that intrapulmonary pressure, inside the lungs pressure, is going to drop. So it's the pulmonary pressure is actually going to be less than that atmospheric pressure. So we start at atmospheric pressure before we inhale. Because of these pressure differences, this is what causes the air to go into the lungs. This is just like any other reaction that we have when we talked about nerves and muscles, nerves and nerves talking, chemicals in the body, everything is going to go down its concentration or pressure gradient. So air is going to keep flowing into the lungs until we get back to our pulmonary pressure and our atmospheric pressure being equal. But when we inhale, we also cause that intrapleural pressure to change. It's going to drop by even more because it was normally at rest, it was at -4. So when we inhale, it lowers down even further by 6. Not necessarily -4. It was 4 millimeters of mercury less than within the lungs. So now it goes down to about 6 millimeters of mercury less than what was in the lungs, or less than atmospheric pressure. But what about forced inspirations or deep breathing? People who exercise, people who have COPD, asthma, any kind of lung condition, they do a lot more forced inspirations than than when you're at rest. Your scalenes, oops, your sternocleidomastoid and your pectoralis minor are all accessory muscles that help you forcefully inhale. If you forcefully inhale enough, you can even activate those erector spinae muscles. Because the scalenes, the sternocleidomastoid, and the pectoralis minor, they're all attaching to the rib cage, that sternum. The scalenes and the pectoralis minor attach to the rib cage to help lift the upper part of the ribs. That sternocleidomastoid, it's attached to that sternum to help lift that sternum. So they all work together to help increase the area for where air can enter into the lungs. And when you forcefully inhale, you're actually creating a larger pressure gradient. So that area is that you're making an even bigger container than a resting or quiet inhalation. And during that time, it allows more air to come in so we can get back to pulmonary pressure equaling atmospheric pressure. That allows more air to enter into the lungs. So this is a chart from your book that just shows the sequence of events for an inspiration. What is happening, what the pressures are like, and what happens at the end of that inspiration. That end of that inspiration, of course, we're trying to get everything back to equaling atmospheric pressure. Quiet expiration is completely passive, meaning not a lot of extra muscles work to create expiration. So, as I mentioned before, that diaphragm is going to go back up to that dome shape. That's the relaxed position. You think because your rib cage and everything expanded when you inhaled, now everything needs to go back down to its resting position. So that thoracic cavity expanded. Now it needs to decrease. Those lungs expanded. Now they need to recoil back to resting position. So when we exhale, we're decreasing the volume of that gas in our lungs. And it causes our intrapulmonary pressure to increase. Just remember, if we think of Boyle's law, we are decreasing the size of that container. When we exhale, there's always air left in the lungs, residual air that's always going to be there. So since there's that residual air, we've decreased the size of the container that air is in, so that pressure is going to go back up. We've now reached the point where pulmonary pressure is greater than atmospheric pressure. And that's where the air leaves the lungs. We want to get our pressure gradient back to where atmospheric pressure and the pulmonary pressure in the lungs are equal again. Another way to kind of think of it is air likes to flow from an area of high pressure to an area of low pressure, kind of like osmosis. Water travels from an area of high concentration to an area of lower concentration. It's the same kind of thing with air. Works the exact same way. What about forced expiration, though? If we are forcing an expiration, could be exercising, we could be playing a musical instrument. Those both use a lot of forced expiration. A wind instrument, I should say, because it doesn't work when you're playing the drums or the piano, but it does with a wind instrument. So that's where the accessory muscles for expiration come into place. Our abdominal muscles are going to compress the abdomen, which causes the diaphragm to go back up to that dome shape. Our internal intercostals are going to squeeze in as they contract and take that rib cage, or that whole thoracic cavity, and decrease its size. So here's the sequence again for both inspiration and expiration. What happens, how the pressures change, and how the size of that thoracic cavity changes for inspiration versus expiration. Here's graphs representing the same kinds of things, the different pressures. The pink graph is showing the intrapulmonary pressure, so that pressure inside the lungs. What happens when we inhale and what happens when we exhale. So you can see we inhale, the pressure goes down. When we exhale, the pressure goes up. Why? We inhale, we have more space in the lungs, which makes the pressure go down. When we exhale, we have less space in the lungs, which makes the pressure go up. Intrapleural pressure is that gray line. So when we breathe in, again, that pressure is going to go from about -4 below atmospheric pressure to -6 atmospheric pressure. Then when we exhale, it's going to go back. The difference between the intrapulmonary pressure and the intrapleural pressure is called transpulmonary pressure. The difference between the two different cavities. Then the blue line down at the bottom, of course, is going to show the volume of each breath. At quiet inhalation and quiet expiration, which is passive breathing. We only breathe about half a liter of air in and out of our lungs at a time. So when we do forced inhalation and forced expiration, of course, we're going to get more air in and out. And that all just depends on how forcefully we're breathing in and how forcefully we're breathing out. It varies greatly. So we even have non-respiratory air movements. So air is always going to be moving during different activities. Like I mentioned earlier, I mentioned coughing. Coughing is actually when that interpulmonary pressure is less than that intrapleural pressure. Sneezing, same thing. When you cry, you actually breathe in and out different air, more air usually when you're crying than when you're passively breathing. Same thing with laughing. Hiccups, that causes differences in the amount of pressure and air you're breathing in and out. Yawns, yawns are usually getting a whole lot more air into your lungs for you could be need more oxygen into your body, so it causes you to yawn to get greater oxygen in quicker. Yawns aren't always because you're tired. It a lot of times has to do with the amount of oxygen that your body needs or requires. So let's look at the different things that kind of influence how air flows in and out of the lungs. We're going to look at airway resistance, alveolar surface tension, and lung compliance. So our airway resistance is the pressure difference and resistance of air flowing in and out of our lungs. So that airflow is actually going to equal the pressure difference between the alveoli and the atmosphere divided by resistance. So if we think about that, if you remember the picture that we looked at on Tuesday showing that respiratory tree, and I know we looked at it last Thursday during lecture when we went through the anatomy of everything. When that air, when everything first comes in, we branch off. Those bronchi, they go to the lobar, then they branch off again. Get those secondary, and then tertiary branches. They continue to branch, and we get those terminal bronchioles. They go down to those alveoli. That is that respiratory tree. If you look at it without the lungs attached, it kind of just, it looks like a bunch of tree branches. That is how it got its name. So whenever we breathe in, the the diameter of all those airways actually gets bigger with every breath in. But as air continues to travel down into the different airways all the way down to the alveoli, everything decreases in size over and over and over again. We cannot actually see alveoli with the naked eye. That's where we have to actually use microscopes to start seeing things. So we start to see air resistance occur in those medium-sized bronchi. But by the time we get to those terminal bronchioles, because they've branched off so many different ways, resistance gets smaller again. It drops. So as air starts to flow from those terminal bronchioles into the alveoli, we're moving to where that gas exchange and everything actually occurs. So this chart shows how that air resistance changes through the branching of the respiratory tree. So resistance first increases, then it's going to drastically decrease once we get to that respiratory zone, which is where we're doing our gas exchange. The conducting zone is where all the branching takes place in that respiratory tree. So as we get more resistance in our airways, it makes it harder to breathe. Breathing becomes more strenuous. We're breathing harder. We're trying to breathe more. So what happens if we get some very severe constriction or complete obstruction in our lungs? So if we end up with obstruction of our airways, we may not be able to breathe. That's what happens when someone's having an asthma attack. Those airways start to dilate. They start to constrict in an asthma attack. But the antidote for an asthma attack is epinephrine. And that's what causes those airways to dilate. So the more constricted the airways are, the harder it is to breathe. The more dilated or larger those airways are, the easier it is to breathe. That's what air resistance is pretty much talking about. The larger the area for the air to flow, of course, it's going to be easier to breathe. The harder it is for air to get through somewhere, you're not going to be able to breathe. So let's look at surface tension. I kind of talked about surface tension before when I was talking about that bubble at the beginning of class today. Well, we have surface tension in our lungs in every single alveoli. That surface tension is created by surfactant. Surfactant is made of phospholipids and lipoproteins, and it helps to reduce that surface tension to make it easier to breathe, but it also helps those alveoli maintain their shape. The last thing we want is our alveoli to collapse, because that would increase surface tension and make it harder to breathe. Surfactant is made by type 2 alveolar cells. These cells are found within the alveoli because they're alveolar cells. They should be found within that alveoli. And they secrete that surfactant that coats the alveoli so that they maintain their shape. So we get that increased, or it decreases that surface area or surface tension so we can breathe more smoothly. So when an infant is born prematurely, their lungs aren't producing the surfactant that is needed for that to create that surface tension or reduce that surface tension. And that is what causes infant respiratory distress syndrome. It makes it hard for the babies to breathe because every time they breathe, they have to reinflate their alveoli. That takes a lot of energy. So if babies are born more than 2 months early, they're not producing the surfactant they need. It doesn't start producing until their last 2 months of development. So that's where natural or synthetic surfactant can be used in the airways to help these babies' alveoli maintain their shape so it's easier for them to breathe. Sometimes, unfortunately, some babies may need mechanical ventilation, but mechanical ventilation can cause bronchopulmonary dysplasia, which is a chronic lung disease in children. And that's the last thing that people want. That's why we try to use some kind of natural or synthetic surfactant in premature babies so they can breathe normally. Compliance. Compliance has to do with how much effort is required for the lungs to stretch. Or change in lung volume that occurs. Normally, we have very high compliance because our lungs and our chest wall expand very easily. But if we have low compliance, it resists expansion. So our lungs aren't going to expand, our chest wall is not going to expand. And it could be because of fibrosis. We may not be producing enough surfactant. Sometimes as we get older, the costal cartilage can start to kind of calcify, which causes a decreased flexibility in that thoracic cage. So pretty much any decrease in that resilience can actually cause lungs to diminish their compliance. Inflammation, infections, tuberculosis. That can cause scarring of your lungs. And if you have scarring of your lungs aren't going to expand very well. Again, if we're not producing enough surfactant, our compliance is going to go down because our lungs cannot expand. If we don't have the compliance, it's hard. It requires more energy to breathe. It's very hard to breathe. Here's an example for you. If you think of balloons, a very thin balloon is very easy to blow up. So it has very high compliance. But a thick balloon, those really thick balloons are really hard to blow up. So it has a decreased compliance. So think about if you have some kind of inflammation in your lungs, you have an infection in your lungs, or you don't have enough surfactant. How hard would it be to inhale to try to reinflate those lungs if you don't have that surfactant and your alveoli are collapsing every time you breathe out? It's really hard. So our compliance, of course, is influenced by distensibility. So even if your thoracic cage, if something is not right within your thoracic cage, that can cause a decreased compliance. If you remember back to the bones section, somebody who has a scoliosis, they have less room for their lungs to expand, makes it harder to breathe. Someone who has that kyphosis, that's a very exaggerated one, but they don't have the space for their lungs to expand, so it's very hard to breathe. As I stated it earlier, in old age, ossification of that costal cartilage, that decreases compliance because it makes it hard to breathe. Paralysis. So you're of those intercostal muscles. So those intercostal muscles just don't work. Maybe they've lost nerve supply or some, but if your intercostal muscles aren't working, you have decreased compliance because your thoracic cage cannot expand with each breath. So there's a lot of different ways to actually assess how well somebody is breathing. There's a lot of different types of machines or different things that can actually see how much air somebody breathes in versus how much air somebody breathes out. And we can use these respiratory volumes to determine the status of somebody's respiratory system. How well is it working? We can take the respiratory volumes and figure out the respiratory capacities, which again tells you how much air somebody can breathe in and out, and that'll tell you the status of their respiratory system. So if anybody has any kind of pulmonary disorders, asthma is one, COPD is another. Those respiratory volumes and capacities tend to be abnormal in somebody who has some kind of pulmonary disorder. So one of the main instruments used is a spirometer. And it measures somebody's respiratory volume. I have one sitting in my bedroom. I don't have an electronic one. That's what they usually use in hospitals, some doctors' offices, but they have others that are more manual that people can use at home as well. So let's look at the different types of respiratory volumes. Tidal volume. That is the normal air that moves in and out every time you breathe. And it's passive breathing. Has nothing to do with forcefully inhaling, forcefully exhaling. That is just passive breathing, what you're doing right now. And we mentioned it earlier on an earlier slide, but it's about we said about half a liter, or it's 500 milliliters. That inspiratory reserve volume, that's how much you can inhale forcefully. How much air can go beyond that tidal volume. It's about 31 to 3,200 milliliters in the average adult male. And it's about, this says about 2,100. I'd see a little bit less, sometimes 1,900 to about 2,100 in the adult female. We have our expiratory reserve volume. This is how much air you can forcefully blow out. And that extra air, about 1,200 in males, and it's about 900 to 1,000 milliliters in females. Residual volume. This is the air that stays in your lungs when you're not exhaling and inhaling. There's always going to be air that's always in the lungs, more that's not going to get breathed out. That's what helps to keep our alveoli from collapsing. So here is a graph that shows some of this. Our normal tidal volume, just this area right through here. Our inspiratory reserve, how much air we can inhale, forcefully inhale. Our expiratory reserve volume down here, how much can we forcefully exhale beyond the normal passive breathing? We're always still going to have some residual volume. We're always going to have something still left in our lungs. No matter how hard you try to forcefully exhale, there's always going to be something left. So this chart shows respiratory volumes, respiratory capacities. It describes what each of them are, and it kind of gives the average for males and for females. It also kind of shows how to calculate, say, your total lung capacity, how to calculate that vital capacity, how to calculate that inspiratory capacity, and how it's calculated for the functional residual capacity. And you take those initials and match them up to the respiratory volumes in the top part of the chart to find what these numbers equal. Since it's all done digitally now, it's done by machines, computers are going to calculate majority of this out for you nowadays. So this just kind of shows how it is found, but computers do it now for us instead of having to sit and do math for everything. Our lungs have what is called dead space. We have anatomical dead space. Gas exchange doesn't happen here. It could be air that remains in different capacities, different places. Because when you're breathing in, not all the air that you breathe in through your nose makes it down to your lungs. That's some of that anatomical dead space. Not all the air you breathe in makes it past the pharynx, the oropharynx, the larynx. That's anatomical dead space. We have alveolar dead space. We have some alveoli that is not functional. That makes up our alveolar dead space. I mean, there's lots of causes, but if we don't have a surfactant in our alveoli, that causes our alveoli to collapse. Could be from an obstruction. Could even be from fluid accumulation in the lungs, like during pneumonia. That's obstructing your alveoli, so you cannot exchange air because there's fluid in those alveoli instead. And then we have our, what is that total dead space? So we take that anatomical dead space and we take the alveolar dead space. We add them together, and that is the total dead space of air or places where air is not being exchanged, or those gases are not being exchanged with the blood. So spirometry, those are some of those tests that can determine how much air is traveling in or out of the lungs. It can also determine obstructive pulmonary disease, like bronchitis. We start to get mucus collecting, and that is blocking some of those airways off. So spirometry can tell us the total lung capacity. It can tell us for the residual capacity, the residual volume. Or the functional residual capacity and the residual volume. But those may increase if we have hyperinflation of the lungs, and that happens in obstructive pulmonary diseases like bronchitis. We also have restrictive diseases. We kind of talked about what restrictive diseases are when we talked about compliance, because restrictive diseases decreases that compliance of the lungs. It makes it harder to breathe. And we could end up with a reduced total lung capacity because of something like tuberculosis. There's different environmental agents that you can breathe in that can actually cause damage to your lungs. And when that damage happens, the way our lungs heal itself. It's the same way the dermis heals itself. Fibrosis, it causes scar tissue. That affects your vital capacity, your total lung capacity, your functional residual capacity, and it affects the residual volume. Since your lungs don't, if we have fibrosis or scar tissue in our lungs, that tissue does not stretch or expand. So it impairs breathing. Can't expand, can't breathe well. So some different tests. We have the forced vital capacity. I've had this one checked numerous times in my life for asthma. That's actually what I have sitting in my bedroom to check every so often. And that's, again, how much air you can forcefully breathe out as fast and as hard as you can. When you're taking one of those tests, that's what they want you to do, is to blow the air out as fast and as hard as you can. And it measures how much air comes out. That forced expiratory volume, that just kind of measures how much gas is breathed out at any given time. Like how much is breathed out in 1 second. A healthy individual can actually breathe out 80% of their forced vital capacity in that first second. Somebody who has some kind of obstructive disease like bronchitis or pneumonia, they're not going to get 80% of that air out in that first second. Even somebody with asthma, they can't. Someone with restrictive diseases, exhale 80% or even more. Depends on the day. Some people can exhale more. Some days I can exhale more, some days I exhale less. And I have asthma. So it just depends. For me, at least, it depends on the day. That's why I got sent home with one of those spirometers to check that every so often. So let's look at our alveolar ventilation. So as we're breathing our air in, it travels through our respiratory tree down to those terminal bronchioles, down to the alveoli. If we're measuring that minute ventilation, that's how much air is flowing in or out of that respiratory tract, getting all the way down to those alveoli within a minute. A normal person takes about 12 breaths per minute without realizing it. If you start trying to count yourself breathing, it doesn't work. Somebody else needs to measure it without you even knowing it to kind of know what your ventilation rate is. But we take in about 6 liters of air per minute. With exercise, you can take in up to 200 liters of air per minute. But that doesn't, it's not the best measure for our respiratory efficiency, unfortunately. Our alveolar ventilation rate is, of course, air flowing in and out of those alveoli. That's the that's what they usually use to check the effectiveness of our breathing, of our ventilation. That can only be checked at the hospitals check it. If you go to some kind of pulmonary doctor, they usually have the machines where they can check that. People usually get referred. You have to get referred for something like to get tested for that. So that alveolar ventilation rate is going to take into account all that dead space we have in our lungs. Tidal volume and the rate of breathing. Our dead space doesn't change. It's pretty consistent no matter how forcefully we inhale or forcefully exhale. It doesn't really change. So that alveolar ventilation rate, it gets affected by the tidal volume and the frequency of your breathing. How frequently are you breathing in and out? So what if that alveolar ventilation rate increases significantly? It's usually because we have increasing tidal volume. So we're breathing in more air at once instead of how many breaths we're taking. Let's say you're panting, you're short, shallow breathing. It decreases alveolar ventilation rate. So this chart just looks at the effects of breathing. It looks at the dead space volume on normal breathing, shallow breathing, and rapid breathing. It doesn't change. Our tidal volume can change because at normal breathing, it's always going to be 500 milliliters, about. But if you take a slow, deep breath, you can double that normal rate. But if you're shallow breathing, you can cut that normal breath in half. Respiratory rate, what I was taught, this is a little high, 20 breaths per minute. I was taught 12 when I was in school because we measured it on classmates and we learned to check this on all patients. Slow, deep breathing, 10, could be even less than that. Rapid breathing, oh, you could definitely get up to 40 breaths per minute. Very easily. So let's start looking at gas exchange. Of course, gas exchange is what happens in that alveoli between the capillaries and those actual alveoli. So we have what is called external respiration, and that is where the gas diffuses between the lungs and the blood. We have internal respiration. That is the diffusion of the gas between the blood and the tissues. So we're not only doing exchanging gases in the lungs when the blood gets pumped back to the heart and the heart pumps that blood back out to the rest of the body, we're exchanging gases throughout the entire body. Because if you remember, that hemoglobin and those red blood cells carries about 4 oxygen molecules. So those oxygen molecules get exchanged out for carbon dioxide in the tissues. We're going to look at the basic properties of gas and the composition of those alveolar gas. So let's start with Dalton's law. So according to this law, each gas in a mixture of gases exerts its own pressure as if no other gases were present. So oxygen has its own pressure. Another gas found in the air we breathe would be nitrogen. They have their own pressure. Carbon dioxide, of course, carbon dioxide has its own pressure. Even water vapor, that H2O, that's for water vapor. They're all going to exert their own pressure, which is actually going to equal atmospheric pressure. The partial pressure is that pressure that each gas is exerting. And of course, because it's part of the whole, it's going to be a percentage of that mixture, because that's what a percent is. It's a part of that whole. What about Henry's law? It's another one. Henry's law says that the quantity of a gas that will dissolve in a liquid is proportional to the partial pressure of the gas and its solubility. So we want to know how well these gases mix with liquids. Well, when they diffuse into our blood, they're mixing with liquid because our plasma is a liquid. This is where we start using hyperbaric chambers. This is how Henry's law was discovered, was using these hyperbaric chambers. And what it does is it uses the pressure to cause more oxygen to dissolve into the blood. And it helps to treat people who have some kind of anaerobic, so non-oxygenated bacteria, such as tetanus or gangrene. So that's where hyperbaric chambers are used. It's used to force more oxygen into the blood for these types of illnesses. So, like these hyperbaric chambers, they're distributing oxygen that is greater than 1 atmosphere. It's usually around 2 atmospheres. If you're doing it for a short amount of time, it's not going to hurt you. But Oxygen can be toxic if we have too much. So if we end up with 2.5 to 3 atmospheres of oxygen in our system, it can actually create a lot of free radicals in our body. Free radicals in our body could eventually kill us. A lot of free radicals our body has a way to get rid of, but it can only do it so fast. Like superoxide. Our body creates superoxide within a cell, but it has the same ability to break apart superoxide within that same cell. But again, if we have too much superoxide, we can't break it down fast enough. So that is what's happening when we get too much oxygen in our system. It's creating these free radicals, like superoxide. Then that superoxide, because our cells can't break it down fast enough, is getting released out. When that superoxide gets into our bloodstream, it can, again, too much of it, kill us. So our alveoli, they contain a lot of carbon dioxide. We have a lot of water vapor in our lungs as well. We have more of that than atmospheric air because the gases are being exchanged within that alveoli. That oxygen is diffusing out of the lungs into the blood, and the carbon dioxide is diffusing out of the blood into the lungs. Water vapor. We need water vapor. It humidifies the air. We don't want to be breathing in cold, dry air. We need, because that causes the humidification that we have within our lungs, within our airways, it helps everything remain its normal size. If we start breathing in too much dry air, we don't have that water vapor in there, it's going to start to cause our alveoli to eventually collapse. So we kind of talked about how we have residual air always in our lungs. So when we're breathing in new air, that's going to mix in with the residual air. That residual air and that new air, they mix every time you're taking a breath. But what is happening is it still allows that oxygen that came in from the new air to exchange into the blood and the carbon dioxide to get exchanged into the air that needs to leave our system. So external respiration, as we kind of said, external respiration is where we are exchanging gases in the lungs. It's influenced by partial pressure gradients and gas solubilities, the thickness and surface area of those respiratory membranes, and the ventilation perfusion coupling, which is that alveolar ventilation with the pulmonary blood perfusion. So let's look at the partial pressure gradients and gas solubilities. So oxygen has a very steep partial pressure gradient. Remember, we said that partial pressure is the pressure of each of the different kinds of gases that we're breathing in with each breath. Even though we're breathing in nitrogen, we're breathing in sometimes argon, we're breathing in other gases, The only gases that we really care about is oxygen and carbon dioxide. So oxygen has that very steep concentration gradient because it is needed in that bloodstream to travel to our body. So our venous blood pressure for oxygen is usually around 40 millimeters of mercury. But in our alveoli, that pressure is usually 101 millimeters of mercury. That's a pretty big concentration gradient difference, or that partial pressure gradient difference, sorry. And because of that pressure difference in that alveoli being so much larger than in the blood, that pushes that oxygen into the blood. Because just like diffusion, we want to equal out our pressures. That is the goal. Is even though that blood is flowing through those blood vessels, we want to even out the pressure between the alveoli and the blood. So by doing that, that's what causes that oxygen to diffuse so quickly and easily out of that alveoli. Takes about a quarter of a second for that equilibrium to be reached. It takes our red blood cells about 3/4 of a second to travel through those pulmonary capillaries. Remember, those pulmonary capillaries are so small that only one red blood cell can travel through at a time. So they're usually traveling in that single file line through those pulmonary capillaries. So even though it only takes about a quarter of a second for that equilibrium and oxygen to be reached in that with that blood, it takes 3 times the amount of time for those blood cells to get through the capillary. Because of that, make sure we get enough oxygen in our blood. That's our main goal. We need to get as much oxygen into that blood before it gets pumped back to the heart to be pumped to the rest of the body. Now let's look at the partial pressure for carbon dioxide. The partial pressure for carbon dioxide in our blood, it's not as steep as oxygen. So in our blood, that venous blood, it's 45 millimeters of mercury. Our alveoli, it's only 40 millimeters of mercury. That's only a 5 millimeter mercury difference. That's not a lot. But it still diffuses just as well as oxygen. Because carbon dioxide is more soluble in our blood plasma than oxygen. But it's also just as soluble in our alveolar fluid as it is in our plasma. So here is the picture from your book. It shows the different pressure gradients within the blood for oxygen and carbon dioxide within our alveoli, in the lungs, within the air that we breathe in the blood that's leaving the lungs, as well as in the tissues. If you notice, the pressures of oxygen and carbon dioxide in the tissues is the exact same as the blood leaving or entering the lungs. But everything still flows where oxygen is going into the blood or oxygen is going into the tissues, while carbon dioxide is coming out of the tissues or carbon dioxide is coming out of the blood into the lungs. It still happens at the exact same rate. So this shows what happens when those blood cells enter the beginning of a capillary and what happens as it leaves the capillaries. So as we show, that pressure of oxygen is about 40 millimeters of mercury when it enters. But by the time it leaves, it's about 104 millimeters of mercury. It's not exactly equal with that of the alveoli, but it's a lot closer than where it was at 40. So let's look at the external respiration. That is where oxygen is getting exchanged with tissues. So where oxygen is being exchanged, it how well it's going to exchange, the rate at which it's going to exchange depends on what kinds of tissues it has to go through. Sometimes it's very thick. Sometimes it's not. Like the area of the alveoli is 40 times the surface area of the skin. That surface area. Because remember, all those alveoli, they all connect to each other. There's tons of these little thousands and thousands of these little alveoli, all connected together. That creates a huge surface area. That allows for a lot of oxygen and carbon dioxide exchange. That is what we want. What happens if we end up with fluid in our lungs or edema? Edema is that accumulation of fluid. We see it in pneumonia, and we also see it in left-sided heart failure. Left-sided heart failure causes accumulation of fluid in the lungs. As we said before, it takes about 3/4 of a second for that red blood cell to get through that capillary. But if there's fluid to go through, that oxygen is not going to transfer from the lung to that blood cell as easily. It's got to travel through a bunch of fluid. Carbon dioxide is not going to leave the blood as easily either. We're going to end up with oxygen deprivation and something like emphysema. The alveoli, their walls break down. So the chambers for the alveoli get bigger, which means there's not as much surface area within that lung for gas exchange. because all those really small alveoli creates a much larger surface area. So if everything starts breaking down, the walls of those alveoli, we don't have that surface area anymore. Which means there's less space for gas exchange. Lung tumors, mucus, like in cystic fibrosis. Cystic fibrosis, they have such thick mucus that starts to accumulate in the lungs because the cells in our, or those goblet cells in our trachea that releases that mucus, and those ciliated or pseudostratified ciliated columnar epithelial cells use that cilia. That cilia increases the surface area of that cell as well, but that cilia helps to, is supposed to push that mucus up into your throat for you to swallow. In cystic fibrosis, the mucus is so thick that that cilia cannot work. So that cilia does not beat. And if that cilia doesn't beat and move that mucus up, the mucus collects down in the lungs. So it blocks gas exchange. Inflammatory materials. Those mast cells love to start triggering inflammation when something happens. That's their job. So those mast cells can trigger inflammation, and that blocks gas exchange. There's a lot of different things that can happen. Here's a typical lung, normal lung here, versus somebody with emphysema. You can see just how big these alveoli have become because of the walls breaking down. You see the difference in the surface area, how much area around all these alveoli for these blood vessels to attach versus this emphysemic lung. There's not as much surface area for blood vessels to exchange, which makes it much harder to breathe, and they end up with more of an oxygen debt. Not enough oxygen to breathe. So we have a ventilation perfusion coupling. Perfusion, of course, has to do with blood. And that blood reaching those individual alveoli. Well, the ventilation is the gas reaching that alveoli. So we need the gas, that oxygen, to get to that alveoli. We need the blood to get to that alveoli for gas exchange to happen. And the rates kind of have to match each other to be very efficient. And our body likes to be as efficient as possible in any task that it does. So just like our heart rate is monitored by autoregulatory mechanisms, so is our breathing. So oxygen controls the perfusion. They can change the diameter of that capillary. So those capillary walls can actually dilate and get bigger to allow more blood cells in. That pressure of that carbon dioxide can change the bronchiolar diameter. So those airways that take the air to and from the alveoli, they can change diameter depending on how much carbon dioxide there is in the lungs. there's too much, they're going to dilate those airways and get more carbon dioxide out. They try to keep those pressures pretty even. So if there's too little carbon dioxide, those airways start to constrict more to let less carbon dioxide leave. So as I just kind of stated, oxygen can change the size of the arterioles in those capillaries. So if we have a lot of oxygen in our alveoli, we need to get rid of some of that. So we're going to make the blood vessels bigger. If there's not enough oxygen in our alveoli, we're going to constrict those arterioles. So it gives time for more oxygen to collect into our lungs. So our alveoli even have a way to completely block off blood to certain alveoli and push it to other places, just like our capillaries do in the other in portions of our body that we talked about a couple weeks ago. So we want our blood to go places where there's a lot of oxygen so that they can actually exchange out the oxygen and the carbon dioxide. Our goal is to pick up as much oxygen when those blood cells go to the lungs as possible. So if some alveoli are kind of low on oxygen, they're going to be like, hey, go somewhere else. Let us collect more oxygen before we start exchanging it out again. That pressure of carbon dioxide also changes things. It can cause the bronchioles, as I said, to change their diameter. We want to get rid of carbon dioxide if there's too much, so that airway gets bigger. Where carbon dioxide is low, those bronchioles constrict. We want to hold on to what we have. We need to have mechanisms to get rid of too much carbon dioxide, but we still need some of that carbon dioxide in that residual air that's still left in our lungs. So our body always has a way to balance this. We need to keep homeostasis within our pulmonary system or our lungs at all times. So we are going to changing the size in the arterioles and the bronchioles. They have to synchronize. They have to, one is happening, the other needs to happen. And that needs to happen so we can keep our gas levels for carbon dioxide and oxygen equal. Sometimes our alveolar ducts get plugged with mucus. And when that happens, we're not getting oxygen to that area. So if we're not getting oxygen to that area, it's going to constrict those blood vessels. It's going to send blood somewhere else to another set of alveoli to get their oxygen that they need. So here's pictures that show what is happening if ventilation is less than perfusion and if ventilation is greater than perfusion. You can see how these capillaries actually start to dilate, while here they start to constrict. So that internal respiration is where we're exchanging gases with the rest of the body. So unlike the lungs, our lungs and our blood vessels have a certain partial pressure for carbon dioxide and oxygen within the lungs. It is the opposite in our tissues. So our pressure for oxygen is always lower than in arterial blood. Why? We want oxygen to leave the blood and go into the tissues. The pressure for carbon dioxide is always higher than arterial blood. Again, we want carbon dioxide to leave the tissues and get into the blood. So these pressure gradient changes, that 40 versus 100 or 45 versus 40 millimeters of mercury, is what pushes oxygen out of the blood and into the tissues, or what pushes carbon dioxide out of the tissues and into the blood. Then, by the time this blood gets back to the heart, pressure of oxygen is 40, the pressure of carbon dioxide is 45. Right where it is when it enters the lungs. So here's this chart again that shows what the pressure is for inspired air, what you're breathing in, by the time the air reaches those alveoli. So remember, there's always some of that residual air. So even though this picture shows what we're breathing in is all oxygen, by the time it reaches that alveoli, we've got carbon dioxide in there still because of that residual air. When the blood is leaving the lungs, when the blood is in the capillaries, what these pressures are, and when that blood is leaving the tissues, where these pressures are. They change in all different places, depending on where they're at and depending on what is needed. Like our tissues need oxygen when it's in the body. Our blood needs oxygen in the lungs. So pressures are going to be different depending on where we're at. So how does our blood transport these respiratory gases? Not all oxygen is carried by our red blood cells. Some of it flows freely in the plasma. Not a lot. About 1.5% is in plasma. Majority of it is bound to that hemoglobin. Fe stands for iron. So the oxygen is bound to the iron on hemoglobin. And we usually can carry about 4, or each hemoglobin can carry 4 oxygen molecules on the red blood cell. So we kind of, when we looked at our red blood cells in the first chapter we looked at in this, in Anatomy 2, we talked about how there were 4 polypeptide chains that makes up each hemoglobin molecule. HB stands for hemoglobin. They all have that iron-containing heme group because that hemoglobin needs to get us our oxygen. And the red blood cells are the most efficient way to get oxygen out to the tissues because that our blood cell or blood vessels carries the blood to all parts of the body. Oxyhemoglobin is a hemoglobin oxygen combination. If we have reduced hemoglobin or deoxyhemoglobin, that is once our hemoglobin has released the oxygen that it was holding on to. So when our red blood cells want to get rid of their oxygen, then hemoglobin has to change its shape. It allows for better binding of that oxygen, but when that hemoglobin changes its shape, it allows for easy release of that oxygen. So when oxygen binds, and we need to increase that affinity, we need that hemoglobin to attract that oxygen and hold on to it. But as oxygen gets released, we have to decrease our affinity for oxygen. So it changes that shape so it doesn't have the places for oxygen to bind as easily. We need that oxygen to leave. We need that oxygen in our tissues, in our muscles, so we can do different things. So when our red blood cells are fully saturated, that means it's 100%. We have 4 heme groups, and they're all going to carry oxygen. Partially saturated, it's when partially saturated, that means not all the heme groups are carrying oxygen. So it could be anywhere from 1 of the heme groups to up to 3 of the heme groups. It could be 1, 2, or 3. That's when it's partially saturated. Just by losing 1 oxygen from that heme group just makes it partially saturated. So that rate that oxygen is being let off into the tissues, sent off to the cells, depends on how saturated that hemoglobin is. What is that pressure for oxygen in that specific tissue? Is that pressure gradient steep or is it pretty narrow? That's going to determine how easily oxygen gets released out. How hot or how cold is it? Is your body? Is that area of your body? Like your fingers experience cold a lot faster than, say, your core. The pH of your blood. The pH of our blood likes to stay between 7.35 to 7.45. So what is that blood pH? Is it a little more acidic? Is it a little more basic? That's going to let us know if oxygen gets released or not. What about that pressure for carbon dioxide? Is the pressure gradient steep like oxygen, or is it pretty narrow? That pressure gradient is going to let us know if we need to release that oxygen, or if there's not a lot of carbon dioxide in that tissue, or if there really isn't any carbon dioxide in that tissue. What that is going to do is say, hey, these tissues don't need oxygen, let's go deliver it somewhere else. Concentration of BPG, that's going to determine whether or not oxygen gets released or not. So if we look at that influence of the pressure of oxygen, if we have that percentage of hemoglobin saturation we can actually draw that on a chart. And it can show the differences in oxygen concentration depending on where we're at. The graph is not going to be linear. A linear graph is something like this. This is a linear graph. Instead, it's going to be more of an S shape, an S curve. And it's called the oxygen hemoglobin dissociation curve. So how much oxygen our tissues need, of course, is going to depend on what we're doing. Are you laying in bed? Or are you out exercising? Of course, if you're out exercising, you're going to need more oxygen than laying in bed. So that's all going to actually determine the pressure of oxygen in those tissues on how quick that hemoglobin is going to release that oxygen into those tissues. So we already had mentioned earlier that that pressure of oxygen in our arteries, it's right around that 100 millimeters of mercury. We have about 20 milliliters of oxygen per 100 milliliters of blood. So we are keeping it at about a 20% volume. We like in our arteries to keep our hemoglobin saturation at 98%. In our venous blood, our oxygen pressure is about 40 millimeters of mercury. And we only have about 15% or 15 volume percent of oxygen. But here's the interesting part. Hemoglobin is still about 75% saturated at that point. That oxygen that's still bound to that hemoglobin in our veins, it can still be transported out to the tissues. It can still be used. Our arteries or our capillaries aren't the only place the gas exchange actually happens. It'll still happen in our veins because our veins travel through tissues. Arteries and veins usually travel together, but there are some areas where veins travel separate from arteries. Because a lot of times we have superficial and deep arteries. And some of those superficial or deep veins. Some places where we have those superficial veins, there aren't arteries right with them. So oxygen can still be used from those veins to get out to those tissues around that area, especially in those superficial veins that don't have an artery following it. So here's that same picture again. This first picture is showing at sea level versus at high altitude. What the pressure is of oxygen and how saturated the hemoglobin is. Because our hemoglobin is about 98% saturated at sea level, only about 95% saturated when you're at a high altitude, or when you're at rest versus when you're exercising. If you're not doing anything, you're laying in bed, we only release about 23% of the oxygen that is being carried around in our blood. But this guy's going for a nice swim. So if you're going for a swim, an extra 35% of oxygen is being used in the tissues. That extra 35% is actually being released out. So we can use that oxygen to help make ATP to keep exercising. So as we talked about, an increase in temperature, hydrogen. That hydrogen affects some of that pH. Pressure of carbon dioxide, PPG, that can all modify the hemoglobin structure and release oxygen. That decreasing affinity is releasing that oxygen out. So you're out for a walk on a very hot day. That's decreasing the hemoglobin's affinity for oxygen. It is releasing more oxygen out into the tissues. If you're outside and it's about 32 degrees out, right at freezing, that actually increases the affinity for oxygen because it's cold. Colder temperatures keeps that oxygen in the blood. So our capillaries is where this actually occurs. Because most, not all, most gas exchange is occurring in those capillaries. Because those capillaries are usually a layer of simple squamous epithelium, which allows for easy, quick diffusion. And if we have that increased temperature, pH, pressure for carbon dioxide, it actually causes a shift in that dissociation curve. Normal body temperatures in Celsius is 38 degrees Celsius, if you did not know. It's about. So this shows what happens to the hemoglobin in your body depending on the temperature. 43 degrees Celsius, it decreases affinity because that's above your body temperature. 20 degrees Celsius, it increases that affinity for oxygen because it's colder. Even 10 degrees Celsius does the exact same thing. So temperature is a huge factor in this. Pressure of carbon dioxide is another determinant of oxygen and hemoglobin's affinity for oxygen. So the purple line is our normal arterial carbon dioxide. That gives us our 40 millimeters of mercury of pressure of carbon dioxide. But what if we get up to 80 millimeters of mercury pressure of carbon dioxide? Or our pH gets to about 7.2. That's going to decrease the affinity of hemoglobin for oxygen. And so that hemoglobin is going to change that shape and release more oxygen. But what if our pressure of carbon dioxide gets down to 20 millimeters of mercury, or our pH gets up to about 7.6? That increases the affinity of oxygen oxygen on that hemoglobin, so that hemoglobin doesn't want to let it go. So there's a lot of different factors that affect, and they're sometimes pretty minute. It determines whether oxygen gets released off into the tissues or not. It's not all just based off of that need. It depends on the temperature, it depends on the pH, depends on the pressure of carbon dioxide. We want to get more carbon dioxide into our bloodstream so we can release it out when we exhale. All of that plays a factor. BPG is kind of a byproduct of glycolysis in red blood cells. So BPG levels go up when oxygen levels are down. Hopefully you talked about it in Anatomy 1. We use glucose to make ATP. We use the aerobic and the anaerobic pathways to make this happen. Just depending on if oxygen is available or not. But we use oxygen, we use glucose to make this ATP. And because of this need for oxygen, then it causes the pressures of carbon dioxide to go up. Causes hydrogen in those capillary beds. That hydrogen is what changes that pH. So if we get too much hydrogen, that pH goes down, causing acidosis. We increase pressure in carbon dioxide, causes that hemoglobin oxygen bond to weaken. That whole thing is called the Bohr effect. So that Bohr effect is when acidosis occurs because we have a decrease in pH, we have increase in carbon dioxide pressure, and that hemoglobin oxygen bond doesn't work so well. Our muscles, every time a muscle contracts, it produces energy or produces heat. So that heat that our body generates every time a muscle contracts is going to affect that affinity for oxygen by that hemoglobin. So as long as you're contracting muscles, those muscles are going to need oxygen because you're going to use that oxygen for aerobic respiration. So as long as we're generating heat, we're going to release oxygen. Let's stop here. And then next time, we will look at how carbon dioxide gets transported through the system. And we will see exactly, we'll look at some different disorders that happen throughout this chapter. And then we will because we'll finish the rest of this before the end of the class period. We'll do a review of the rest of this information of the entire respiratory system for what we need on the for the test. So I'll put that together before next Thursday. So if there are no questions, everyone have a good evening and a wonderful weekend.
Thank you.
You're welcome. Good night.